Good morning all. At the outset, I would like to thank Dr. Natasha ma'am and APAO for the opportunity, and I do not have any financial interest in the topic being presented. So, we all by now know that glaucoma and uveitis do coexist. And first pearl is that uveitis is the second most common cause of secondary glaucoma, second only to cataract and cataract surgery related complications. If we consider all causes of uveitis, 10% of all the uveitis have glaucoma itself, uveitic glaucoma. I am not talking about uveitic hypertension, ocular hypertension. Higher prevalence of uveitic glaucoma is seen in anterior uveitis, older age presentation of uveitis, and chronic inflammation. So by now we are familiar with two terms, uveitis related ocular hypertension, where you just have an increased intraocular pressure, there is no disc damage and there is no corresponding visual field defect. But when you have a disc damage and a corresponding visual field defect, you call it uveitic glaucoma. So there are two different entities. So when you see a patient of uveitis, you have to keep an eye on the eye pressure. Do look for disc changes also. Do look for NRR, neuroretinal rim changes. Look for RNFL defects. And definitely have a timely IOP and glaucoma management. Watching the disc and also doing visual fields for disease identification and progression is quite essential. But it is not as easy as a primary glaucoma. This is because many of the uveitis patients are symptomatic at presentation. They usually tend to do poor visual fields because of the symptoms itself and because many have poor vision. And the view to the disc itself is hindered by the opacities, and hence glaucoma detection itself is challenging. The second pearl here is one size doesn't fit all. What it means is there are varying causes for uveitis and the mechanism of glaucoma also varies. But it is essential to find it because clear diagnosis and appropriate therapy depends upon that. Based upon the angle structure, glaucoma is either open angle or angle closure. Based on the cause, it is acute or chronic. Based on the severity, hypertensive uveitis or post-inflammatory glaucoma. Based on the uveitis, non-granulomatous, granulomatous, based on the cause, infectious, autoimmune, systemic, idiopathic. And there is a better classification. Based upon the IOP and inflammation correlation, you have inflammatory ocular hypertension syndrome, where the examples are herpes, Posner, Schlossman, etc., where you have the inflammation and the IOP peaking and coming down together. When there is an acute uveitic angle closure, the inflammation and the IOP peaks together. The inflammation comes down, but the IOP does not come down along with that, because when the angle closure comes down, when the angle closure reverses, at that time only the IOP comes down. When you have corticosteroid-induced ocular hypertension, what happens? The inflammation sets in. You start steroids, but once with the steroids, the inflammation comes down, but the IOP goes up. The timeline is shown in the x-axis of the picture. What happens in chronic mixed mechanism ocular hypertension is that there is waxing and waning of inflammation, and slowly the IOP starts to increase, and constantly the IOP remains elevated if not intervened. The third pearl here is about Fuchs heterochromic iridocyclitis. As previous speakers have spoken, we see that it behaves little differently. It's a chronic non-granulomatous low-grade anterior uveitis with insidious onset. It is mostly unilateral. Some might have bilateral disease. It is characterized by diffuse small stellate KPs, posterior subcapsular cataract is there, but secondary open-angle glaucoma is common. Amsler sign we might have heard about, which is the trickling of blood from the angle when you do gonioscopy, AT, or when you do decompress during cataract surgery. It is characterized by no synechia, posterior synechia or peripheral anterior synechia formation. Heterochromia is there. This is the Amsler sign. They are different because there is poor response to steroids. So you don't have to load the patient with unnecessary steroids to produce a steroid response. Controlling inflammation as such is not correlated with effective control of IOP. In many of the Fuchs cases, IOP control is not achieved by medicine and surgery will be required. Many of the patients has a viral etiology. So if the viral etiology is proven with PCR, treating with systemic virals helps in IOP control also. So is PCR a saver? That is the fourth pearl. AC tab for PCR for viral DNA, especially in atypical presentations and unsatisfactory therapeutic responses. It is important because it differentiates the infectious from the non-infectious and identifies the agent. So if you target the agent, then again control of IOP gets better. Topical antivirals may be useful in keratouveitis, but as such not in uveitis alone. Then other pressing question is prostaglandin analogs useful in uveitis or not? Definitely prostaglandin analog like latanoprost, travoprost and bimatoprost are pro-inflammatory, agreed, and should not be used in active inflammation and viral uveitis because they definitely increases the risk for reactivation, especially in this herpes and CMV viruses. There is risk for reactivation and should not be used. But they are quite okay to be used in white eyes and non-infectious type of uveitis. What about PG analogs if you have an NSAIDs, topical NSAIDs being used? Topical NSAIDs inhibit prostaglandin and hence the effect of prostaglandin analog will be less when you have a topical NSAIDs. What about pilocarpine? Cholinergics are contraindicated because breakdown of blood aqueous barrier happens. It promotes posterior synecdoche. Brimonidine. Brimonidine is also found to be pro-inflammatory. So if you have an inflammation going on in spite of appropriate treatment, and if the patient is on brimonidine, you can have a suspicion of brimonidine being pro-inflammatory in that patient and can stop brimonidine for that patient. Usually what happens is that this pro-inflammatory action in this brimonidine sensitive patients, they also have surface issues. So that will be a clue for that. What about the new Rho kinase inhibitors like ripacidil and all? They also have this anti-inflammatory effects along with this ocular hypotensive effects, so that the Rho kinase inhibitors are also useful. So drug of choice, the first line are those who reduce aqueous production, the topical carbonic anhydrase inhibitors and beta blockers. Second line will be alpha agonist and Rho kinase inhibitors. Of course, when there is the eye is quiet and that is a non-viral uveitis, prostaglandin analogs is okay. Contraindication is for cholinergics and like pilocarpine. If you had a sudden acute elevation of IOP with very high IOP, systemic carbonic anhydrase inhibitors and hyperosmotics are indicated. When to and when not to shoot. So when a patient presents with secondary angle closure as in Uveitis syndrome, here what happens is not pupillary block, it is the ciliocoroidal effusion, ciliary body swelling, and we can see that the ciliocoroidal effusion leads to ciliary body swelling and angle closure. What you should do, after treatment, you see that the ciliocoroidal effusion has resolved, the ciliary body swelling has resolved, and the angles have opened up. Here we have not given pilocarpine, we have not done laser peripheral iridotomy. What we have done is treatment of the VKH and have given cycloplegics. So we need to identify when to shoot, when not to shoot. But in these conditions where it is a frank pupillary block, iris bombay, we have to give them proper treatment with laser iridotomy. This frank iris bombay, you don't have to treat as in a PSCS or PAC, primary angle closure. You can directly go ahead and give a laser iridotomy. At the most convex portion, directly penetrate with the first shot itself. You have to have a large PI and you have to give multiple PI also because it could be a loculated, multiple loculations of the multiple loculations, and because of the inflammation, these PIs tends to close off. Coming to the steroids, steroids are known to be the double-edged sword. It needs to be given for the inflammation to be controlled, but many patients are steroid responders. So it decreases the outflow facility. It's least with the systemic steroids, most with the topical and the periocular steroids. Triamcinolone and prednisolone has the highest steroid response. Loteprednisolone, fluorometholone has the least likely, usually 2 to 6 weeks after starting. But if the patient has already had a previous episode of steroid response, the next time when you give, it can actually manifest even the next day of starting steroids. So if the patient has developed immediately after starting steroids, it does not rule out a steroid response, because if the patient has earlier had a steroid response, it could immediately have a steroid response again. The risk factors again is unrecognized POAG, family history of glaucoma, extremes of age, both young and old, diabetes and rheumatoid arthritis. What is the cause? Because of the biochemical and the morphological changes in the trabecular meshwork. And what happens if you stop steroids at the correct time, the trabecular meshwork changes back, reverse back, and the IOP is going back to normal. If you give depot steroids, you have to follow up the patient very early at 1 week. If it is topical at 2 weeks, if it is systemic at 4 weeks. Management, shift the patient to lower potent and newer steroids, or switch the patient to immunosuppressants or biologics if long term is required. If it is a depot steroid that is like subtenance that is given, then you have to excise that steroids. And if it is an intravitreal in Ozurdex, you can do vitrectomy to remove that Ozurdex. But if it is actually indicated, if the Ozurdex needs to be there in place, then you can go ahead and do a trabeculectomy. What we have seen is that trabeculectomy works better if there is a cover of steroids. So the next pearl will be, first establish the cause, see what is the underlying pathology and treat accordingly. If you have a turbid aqueous trabeculitis, you treat the uveitis, manage with the anti-glaucoma medication. Iris Bombay, if you have an Iris Bombay, whatever amount of medicine you give without a PI, it is not going to revert. Steroid induced, remove the steroid, give an immunosuppressant. And if at all with this medicine management, it is not getting control, you have to opt for surgery. All is not lost when medicine fails. You can do surgery, trabeculectomy with mitomycin C, under steroid cover, that is very important, and antiviral cover if it's a viral cause is detected. There is an increased risk of failure both on the hypotony side and also bleb scarring side. Both the type of failure can happen in uveitis, and hence better success is seen with drainage implants. We have two types of drainage implant. One is with valve and other is the non-valved ones. Valved ones are preferred than the non-valved ones. That is because valved ones, the risk chance for hypotony is less. We are always more worried of hypotony because of the ciliary shutdown, all those issues in uveitis. What about SLT, that is laser trabeculoplasty? It sets in more inflammation and hypotony risk is more. So it is not that preferred as in any case of open angle glaucoma. The newer mix, that is minimally invasive glaucoma surgery. In that, there are some procedures we call stenting. Small stents are put in the angle of the eye, but they tend to get blocked because of the inflammation and fibrosis that happens. The canaloplasty, which we call the cutting surgeries, that tend to work little better. So uveitis and secondary glaucoma because of that is a major cause of visual morbidity. Early detection and adequate management of IOP is crucial. Identifying the mechanism of glaucoma, addressing the underlying cause of uveitis improves the long-term outcome of the patient. Monitoring the disc and field and watching for progression is very essential. Collaboration between the uvea, glaucoma and also the immunology part of it is quite essential, and it is a challenging disease to treat, not for the doctor alone, it is also challenging for the patient. So patient education is very important. Thank you for your patient listening.
Thank you, Dr. Jayasree, for an excellent overview of management of glaucoma in uveitis. I have a few questions for you. What is your experience with Ripasudil in uveitis? I have found at least 2 patients in whom the glaucoma specialist started Ripasudil and the patient developed limbus to limbus corneal edema in children. And that corneal edema actually took a long time to subside. It was very difficult to explain to the patients that it is not because of the uveitis itself.
The issue with the Ripasudil is that Ripasudil tend to produce this epithelial edema, that honeycomb edema in some subset of patients, and more so when they have a compromised endothelium. So that is a known entity, and it tends to go off by itself once you remove the Ripasudil. That is a non-entity, especially when the corneal endothelium is compromised.
There is no way we can know which patient will develop it.
There is no way.
Is there any increased propensity in children?
Actually, Ripacidil and all, we are not regularly starting for children, ma'am.
It was started as the last line, but because just before going in for surgery, patient was already on all the other medications. But I found this and then it kind of worsened the situation quite a bit.
And in uveitis, already it is a red eye, and Ripacidil and all those things, we have to tell the patient that it is going to be a very like tomato ketchup type of redness can be expected type of counseling needs to be given to the patient. But this honeycomb epithelial edema reverts.
Okay. So probably better to do it as last resort. Then second question is, when you're doing PI in angle closure in uveitis, most of the time the inflammation is not controlled. So is it okay? What is your experience with the inflammation? Does it go up after the PI?
So in pupillary block, there is no other option other than doing a PI. So whatever be the level of inflammation, if it is like very severe, this type of pupillary block, if the patient is not in ciliary shutdown phase, will be very symptomatic. So we have to do, because then only it will relieve the symptom of the patient, and hence we do, and we give a significant cover of topical, and if as indicated, if indicated, we have to give a systemic cover also.
So there is no contraindication. You have to go ahead and do the PI, isn't
Yeah.
it?
And otherwise, with a high IOP, the optic nerve also gets the backlash.
So you also said that most of the surgeries that is preferred is the valved implant. But in my experience, a lot of my glaucoma surgeons are doing the RD implant. So is there a major difference between the two, or is it okay to go ahead with the non-valved?
The thing is like hypotony is a major issue. This inflamed eyes, uveitic eyes, the risk of hypotony is a major problem. We have mechanisms to control hypertony, but there is no mechanism to control hypotony. So that way, a valve is always preferred.
Okay. Are there any questions from the audience?
Yeah, can I?
Yes.
Yeah. Is there time for a question? Yeah. Here.
Yeah, I think.
Okay, Natasha. Yeah.
We have 15 minutes, so there is time. I can't see where you're speaking from. There you are. Yeah, tell me.
I'm not a very tall person.
Treatment of glaucoma to cyclitic crisis.
Yeah, can I complete my question?
No, there is a question from there, sir. First, let's take that first.
So I just want the opinion of the chair regarding glaucoma in uveitis. It's a very difficult proposition, you know. So we have been brought up saying that from the postgraduate times that travoprost or any of the PG analogs cannot be used in uveitis, in the setting of uveitis. But the evidence is not great, honestly. That is one thing. Second is, as a person who have been using, when you have people who are on travoprost or something, during cataract surgery, we stop that and then switch over to some other drug, less of anti-inflammatory thing. And then once you complete the cataract, you go back to travoprost. That was the thing. But what we have realized is that it doesn't really make much of a difference. So is it really, is travoprost or latanoprost really so much cause inflammation? Because the evidence, what they say is, I think, if you're based on a very few case reports.
I think Dr. Jayasree has already said that. I'll give the mic to her.
So nowadays, we don't stop prostaglandin for cataract procedures. And if at all, the risk for CME as such with the topical...
No, I'm not asking about cataract. I just cited it as an example. Okay. I'm asking in uveitis, see, because you have very less options. Either you go for systemic this Diamox, or you have to go this napazidil and netrazidil. They are not free from complications either. So we have limited options, and you need a drug which causes 30-35% reduction in intraocular pressure.
So you can give prostaglandin analogs if the uveitis is not active, if it is not because of viral etiology. and you have to warn the patient about the risk of activation of uveitis. So if the patient comes with symptoms, you have to warn the patients that there is a chance of uveitis to come back, and ask the patient to come back if the patient like gets back the symptoms. That is the only thing. Just warn the patient, but you can start, sir.
Practically, in our experience, prostaglandin analogs do not create. If the uveitis is fairly on its way to getting controlled, then PG analogs don't really
that
add
is one
to
thing
the
I want to bring,
inflammation.
because the literature is,
Yeah.
There is, like,
Practically, in
generally
our
speaking,
practice, I don't think any of us face that problem. We always add it once the glaucoma is not getting controlled with the first line CA inhibitor and beta blocker. Next, we add prostaglandin analog usually. And even cystoid macular edema, at least in my patients, I have not seen after prostaglandin analogs.
okay, thank you.
Somebody else had a question. Yes, sir.
Treatment of glaucomatous cyclitic crisis, Prosner-Schlossman syndrome.
Sir, usually the patient will be very symptomatic. Patient usually presents, and it will be like multiple episodes. When the episodes happen, the patient comes, you immediately start the steroids. It responds within no time. And as the inflammation subsides, the IOP also subsides. As the IOP is increasing, immediately you start the medications, anti-glaucoma medications. That the high IOP needs systemic assistance also. So when you start the medications, it immediately comes down. There will be few more episodes like that. Because now what we are seeing is that there is a viral etiology to it. So if the patient is getting recurrent attacks, then you are advising, you have to advise the patient to undergo PCR also.
Aquastap, and you may need antivirals for at least 6 months to stop the recurrences.
I have seen a patient in 17 years old, 17 years, first attack. So he has 60 millimeter Hg of IOP, treated with Diamox for 7 days, and he asymptomatic for 4 years. Then he again came to 1 week back with same pressure.
Okay.
I see the previous prescription, intraocular pressure is 60 millimeter and other eye 18.
Okay.
And we have given the Diamox and Brivex, glucomol and brinzolamide something.
I think if you have a 4-year gap.
But I have not given the steroid. Previously I have not used the steroid, so I don't give the steroid. After seeing the patient, I have seen the literature. So steroid I am not given.
Okay.
So I think steroid should be added, na?
You should add, because
should
it is trabeculitis
But,
that is
because
causing
of the high pressure, I get scared that steroid will also increase the pressure.
No, in this particular condition, you can safely add steroid because it will help in control of the trabeculitis and it will help in control of the IOP, but you don't need like a long-term tapering
steroid,
like we do in other
Yes, 1 to 2
conditions.
weeks of steroid.
Yes.
Okay, thank you.
Thank you.
It is the inflammation of the trabecular meshwork that has led to the increase in the IOP. So without that inflammation subsiding, the IOP is not going to come down. So you need to target that also.
Okay.
So anti-inflammatory is required.
Some other question?
Yeah, thank you, ma'am, for nice talk. I just wish to ask if we are injecting patient with intravitreal triamcinolone acetonide, so do you advocate giving empirical anti-glaucoma medications at same time, or if we find him later a steroid responder, then only to add?
We don't give anything empirically. We have to look for steroid response and then only give. There are no family history and all we can ask, but then you cannot predict for sure, no?
Okay.
But generally, we are all moving away from intravitreal triamcinolone.
I think two things are very important here. Like if a patient is a steroid responder, you need to plan your treatment very differently. If it is a non-infectious uveitis, I'll give you a classic example of a HLA-B27 associated uveitis, who is a known steroid responder. These are the patients you need to shift early to the immunosuppressive, because you need to bring down the chances of recurrences and inflammation significantly. Number two, any patients of uveitis, if you are not sure, patient has suddenly come to you, you don't have a proper follow-up to know or understand that whether the patient is a steroid responder or not, don't give anything which you cannot take back, like giving suddenly a tricot injection, and decision to give a suddenly intravitreal injections can be dangerous for the patient. You should not invite it another trouble for the patient. You trying to treat the intraocular inflammation, if you are giving some intravitreal injection and you lead to again secondary glaucoma, so that's not going to help. So I think these are the points you should remember always treating a case of uveitis.
Yes, sir. Thank you, sir. So one more question to all the panelists about quantiferon TB gold test. So how it is added up in your evaluation of uveitic patients?
I think Mudit already answered it very nicely.
Yes,
that any kind of laboratory test, we don't read the laboratory test. It gives you a supportive actually evidence so that you can help in your decision making. So the quantiferon test is same only. Just because patient is having quantiferon test positive doesn't mean that you need to give a ATT if there is no other associated signs or any other evidence. So like any other test, you have to take that.
If you're asking between Manto and quantiferon,
Yes.
whether
What extra edge you get with that?
I have almost completely shifted to quantiferon, except in patient who absolutely cannot afford it.
Okay.
Because it gives you a more like an objective value. It is either positive or negative. So your confusion in your 12 millimeter Manto, 15 millimeter Manto becomes to a large extent taken care of. At least that is one less thing to worry about, is my take on it.
I have a slight different opinion because I always value Monto very high, because if you are dealing with a granulomatous anterior uveitis, if you do a Monto, if it comes positive, it's good for me that at least I have some suspicion. Even if it is negative, I know that in sarcoid patient it can be negative. So it can help either way, but I agree with Natasha that yeah, quantiferon you may do, but it's better if you can do both the tests, if the patient can afford.
Let's take one last question. I think our next session people are here already.
Ma'am, I have a question regarding the Posner-Schlossman syndrome only. So I had a patient who's a middle-aged male, and he had an episode of acute uveitis. And we all know that we have to start steroids, topical steroids, along with NSAID. To reduce the inflammation. I also started the same, but the IOP it still got increased, and in the next visit I recorded an IOP of 50 to 60 millimeters of mercury. So I started on Diamox for the same patient and to decrease the intraocular pressure, and within a week the pressure got reduced, but as soon as I tapered the steroids, I had started prednisolone first, and then I moved to dexamethasone. Because of the IOP spike, I thought he's a steroid responder.
Okay.
So my confusion is like in a patient of Posner-Schlossman.
Can you reduce the music, please? We are taking a question here.
So in a patient of Posner-Schlossman syndrome who might be a steroid responder, how do we approach such patient to reduce the IOP and the steroids? How do we manage? Because for the
No, when we are talking about Posner-Schlossman as such, the presentation will be with raised IOP with very minimal inflammation, because the inflammation is predominantly in the trabecular meshwork. You will not see it in the anterior chamber as cells. If you have a very symptomatic uveitis to start with cells in the anterior chamber, it is unlikely to be Posner-Schlossman. You are dealing with uveitic glaucoma. So that is the difference. So in Posner-Schlossman, predominantly you need your IOP control with secondary steroid help. In the other conditions, you will need predominantly steroid with IOP control. I think they want us to dance now. I'll take your question personally.